Hello Charlize, thank you for coming and joining. We're going to be going over a suturing workshop today. It will involve a lecture in the beginning and then we'll be suturing on a picture. Do you have any objections to that?
No.
Perfect, we'll get into it. So these are our outcomes for today and you can have a read through them on your own time. We're going to be mainly looking at number 4, which is be able to perform the basic suturing techniques, including simple interrupted, vertical and horizontal mattress, subcuticular and continuous sutures, which could be assessed at your end of year OSCE. So the goals of suturing, there's 4 main ones. It's bringing the 2 edges together to promote healing, assist in hemostasis, wound infection control and minimize scar formation. Quick anatomy, I know you've probably seen these slides many times, but the main part is the epidermis, dermis and subcuticular layer, and recognize that there's nerves, blood vessels, pore and sweat glands inside as well. Wound closure, there's 3 main types. We've got primary intention, which is the wound is closed with a surgical intervention as shown by top. It's the best choice for clean, fresh wounds and to help with hemostasis. Secondary intention is just leaving the wound to close by itself. This is useful if the wound is contaminated, but it does cause increased scarring, as you can appreciate here, because it's just closing on its own and it's a large area. And tertiary intention is delayed primary closure, so letting it heal by itself, and that's if there's something initially inside it or something that's making it infected, and then afterwards we can close it with primary closure. Local anesthesia, we won't be doing that today, but the basic principles is choosing the site and what sort of anesthetizing you want to be doing. So for most suturing you just put local, which is lignocaine, into the area, but you can do nerve blocks if it's a bigger area. Different types of lignocaine, 1% or 2%, and you can have with or without adrenaline. The main thing with the adrenaline is you can't use on end artery supplies, which is your fingers, your toes, tip of your nose, the clitoris or the tip of the penis, because it stops the blood flow to the area. And also it is very painful, so use a high gauge needle and warn the person beforehand. Equipment, as you can see before you, we have the needle holder, the toothed forceps, serrated forceps, and the iris scissors, which we'll be using today. Different types of sutures, you can have absorbable or non-absorbable, as the name suggests. One of them degrades quickly, but it has a increased of wound failure for the absorbable ones because they can absorb before the wound is healed over, and it loses its strength quicker compared to non-absorbable, which are permanent in the body and will hold their strength for a lot longer, but it is a permanent foreign body and more likely to cause infection, and you have to get the person to come back in to cut them out. The origin, it can be natural or synthetic. Most of the time you'll see a synthetic because it causes less tissue inflammatory response, which is the monocrol, bicrol, if you've heard those words before. And then the fiber configuration, so monofilament versus multifilament. Monofilament meaning one strand, so it passes through the tissue easier, but it is a lot harder to knot because it's a bit more slippery and it's a lot more likely to break due to it being stiffer compared to monofilament, which is multiple fibers. It's a bit stronger and more flexible and easily to handle, but when you put it through the tissue, it's more likely to sort of rip and break through the tissue because it's made of a lot more fibers. And then you have the size. So 3 is the largest to 9/0 being the smallest. Okay, so knot tying involves the tying the 2 sides to create a square knot. Difficult to talk through here, but that's why we've got the string, so we'll go through that. And then different types of suturing technique. So we've got simple interrupted, which is, as you can see, it's just the one layer through, compared to continuous, which you can see down here, which is continuously going along. Then you have subcuticular, which just goes through the dermis space, which is that one there. And then mattress, which is horizontal and vertical. A couple of differences with the mattresses, they're used for wound edge aversion, and if the wound's over a large space and there's a lot of tension on it. So the horizontal is better for larger gaping wounds to like pull it together with tension, while the vertical mattress is better for wound edge aversion if you want to push it up. Common pitfalls, incorrect placement of your hands on the instruments, which we'll go through, and the incorrect placement of the needle in the needle holder. And if you don't penetrate the skin with a 90 degree with the needle, all of those things, they just change how the skin heals, and we'll go through them a bit easier to show you than talk through it. Uneven suture placement, as you can tell, if the suture's uneven, it's going to heal uneven, or if you have excessive tension on the suture as well. And either leaving the tail in too long or too short. Too short, it's more painful to get out, and if you leave it too long, it can get interrupted in the other sutures. Slip knots can be caused because when we go through the tying, you tie it in one direction and then swap directions. If you do the one direction the whole time, it can cause a slip knot, so it's not a tight knot, and then the wound could break open as well. And wound dressing, so the incorrect dressing or bandage or not drying beforehand can lead to the risk of infection and wound breakdown. And it's important to know there are other options other than suturing. So we have glue, staples, and wound enclosure tape, which is Steri-Strips. So the glue is useful for small wounds that you can approximate with your hands, but they have to be cleaned very well because this glue encapsulates everything inside it. Staples are good because they're quick and they're less of a foreign body reaction, and it's useful for hemostasis. You're more likely to use on the scalp as well, but it doesn't allow for close or particular suturing or careful closure. And then the Steri-Strips can also be used with some sort of sutures like the subcuticular, just to give it that extra sort of help. Perfect. That was the lecture time. We'll go through the tying of knots, and I'll get you to tie a couple knots while I go get the other things. So we're going to pretend that this is the, you can grab your needle holder, which is this one here.
Yes.
And that will be in your dominant hand. Fourth finger through this hole and your thumb through that hole. It's important to not sort of grasp it like this, because if you imagine you don't have much sort of use, but when it's on your fingertips, you have a lot more use. Get your toothed forceps. The toothed ones are much better for skin aversion, because if you appreciate, if you use this on skins, it's just gonna break the skin tissue, and it's always going to be a suture. The black end is going to be the needle end. So you've already put it all the way through, and then you've pulled the needle end all the way through like this. So you've got a short end and a long end. And what you want to do first is you're going to put you can put that one down for now because we're using this one with the hands. You make it a U shape. It'll be easier with the material, but this is going to be like a big U if it was holding up and up like that. And there's your needle forceps always going to be in the middle of the U. And you get this side, and you're going to wrap it around once, wrap it around twice, then pick up your small side, and then remove your needle holder for a second, and then you're going to pull opposite directions. And see how that's created a knot that is sort of like, it doesn't look like a slip knot, it looks like a square knot right there. And you're going to pull that all the way down. And then you're going to go again. Once, so twice on the first side, once on the other side, opposite directions, make sure it hasn't created a slip knot, and then one more time around that way. Always inside the U, and then pulling as tight as you can. So now you have a go of that. You want to grab it along here, and it's got to be 2/3 from the tip. See, there's the tip and there's the thing. It's going to be 2/3 along, and it's also important not to hold it too far in. So that would be too far in. And you also want to be 90 degrees. See how that's not 90 degrees. So you want to hold it close to the edge, and always remember use forceps instead of your hands to hold the needle to avoid needle stick injury. What you're going to do is directly 90 degrees in. You're going to be about 5 millimeters from the edge of the wound, and you go directly in, rotate your hand, and then you'll come out through the middle. And we're going to practice coming out through the middle and really grasping. Sometimes you can do it all in one bite, but that's not what we're going to do today. And then make sure you grab the skin, evert the wound edge, pull the wound edge like that, and you'll start from one end and go down to the other end. Put it in the U and do it, and you can do it. See, I'm doing it very close to my needle holder with my hands. You can do it a lot closer because then you're not fighting. Yeah, and then so you do twice for the first one. Grab it very close to the edge. You don't want to pull too tight. Because if you pull too tight, if you have a look at the skin, you can see that it gets pushed in down. And the distance that you want to cut is how close your sutures are going to be. So if your suture's about 5 millimeters apart on the cut, you want to cut your sutures around 5 mils. So the next one that we're going to do is a horizontal mattress suture. And if you have a look at the picture here, it pretty much is a simple across. So you go one simple across, then you go down, and then you go simple back the other way. So simple across, instead of tying it, you go back in and down, which will involve you having to reload the needle, but it'll be the opposite way around. So we'll start by both doing one simple interrupted across. So in around 5 mils. So normally you would load your needle this way. What we're going to do is we want to load it the other way. So you can just hold it like this, and you grab each end and you spin it, and you go the opposite way. And now we want to create a box-like structure. So you're going to go 5 mils down the cut and go back in and back out the other way. Usually what we would like to do start is start from one side down to the other. So you go in that side and then out that side, and then in that side, out that side, so it's backwards. That's okay. So now you've got your 2 ends like this, and you're pretty much going to tie them again. Do you remember what I said these type of mattress sutures are good for?
Large surface area.
Yeah, that is pretty much it. Large gaping wounds.
Yeah.
Because if you can appreciate here how you've got side to side, you've pulled it all in like a box-like fashion instead of just one line across of tension. It's a bigger box tension. And yes, next we're going to do the vertical mattress, which is, see how you go here. You're going to go in far, out far, and then you're going to go in deep, close, out close.
Mm-hmm.
So you start now about 1 centimetre away, in far, and then out far. Again, you're going to load it backhand, pull that through, and then you're going to go, sometimes when you go backhand it's easy to change your hands like this, in line still, so it's still going to be in line, in close, so you go halfway from when you came out to where you're going to go in through the cut, and then you're going to go out close again, that halfway mark, if you can appreciate on mine here.
Mm-hmm.
Small end here, long end here. See how it's already everting the skin?
Mm-hmm.
And then we've got our short end, our long end. 1, 2, inside the U. Pull it. They're going to swap sides like that. And see how as I tighten it, it everts the skin.
Yep.
Okay, so we're going to do a little bit of a feedback session. So it's going to run by, I'm going to start asking you first about how you thought it went, what your strengths and weaknesses were, and then I'll give you some feedback as well. So how did it go overall?
I think it went pretty good. I've only sutured like once or twice before, and I can definitely see like a huge improvement from the last time I sutured, considering that it's obviously not something that I've been like keeping my skills up and been doing all the time. So the fact that the last time I sutured was like 3 or 4 months ago, I'm impressed that I did have a little bit of recall, but yeah, I think I did a really good job with all of the different techniques.
That's really good feedback. What's something do you think you could work on?
Just keeping my like sutures in line. I think some of my sutures were like maybe a little bit off, which I know like is pretty big for when it comes to a real person's skin and wound healing. I also did find it a little bit difficult to see like where I was suturing with the clear suture, so I think I should start practicing with maybe some more blue or the black sutures a bit more before I get into the clear sutures.
Yeah. No, I definitely agree with what you're saying. So with your strengths, I think you said you've only done it a couple times. You did sort of get the whole understanding of it. You knew how to properly hold it, which is a big thing. And like you seem to understand the different types of suturing and when you do them and the process of going in, going out, that 90-degree angle, that was also useful. I hear what you're saying without like slightly misaligned, but also we were using like a peak trotter, which is also difficult. So real skin is a little bit different and a little bit easier in that regard. Something that I noticed that you could have worked on is when you're tying your knots, like you weren't really tying your knots properly.
What do you mean by not properly?
Oh yeah, so it's not properly, but when you tied them, you would pull one direction, then you'd pull the same direction again. Yeah, so change your words about, so you'd pull one direction and then maybe pull it the other direction. That's something that you can just change with time. It's not like you're bad and you're not doing it right. It's just doing it repetitively over and over. You'll soon just like do it unconsciously. So that's something that you could work on. Now, an action plan for you going forward, things that you can do for next time. And you've got really good technique. It's always useful to continuously practicing. So you can use like foam, or like you can buy fake skin or fake arms and practicing your techniques, especially if like with the alignment, practicing going in one side and then out the other side in line. Obviously you can't control what goes through the doors of the hospital, but if there is anyone who would getting that skin procedures, ask the doctor if you can practice with them, watching, getting advice from other doctors as well. Do you have any feedback on overall the whole session, how it ran? Any feedback for me as your facilitator?
I really liked the structure of the little lecture and then actually getting like a practical scenario after getting the lecture. It was like a good system that you were running. I also liked the information that you put in, because obviously this is something that I have been introduced to before, but it was nice to get a refresher, and I feel like the way you pitched it was to my learning, so that was really good. Yeah.